A couple of things I just wanted to talk about as regards anti-seizure medicines pharmacology. One first lesson for today is that it's no longer anti-epileptic drugs, it's anti-seizure medications, largely because they don't prevent genesis of epilepsy, they prevent onset of seizures, and they're not drugs, they're medications. So this is the new fashion, so ASM from now on. And it's just a quick chat about some lessons, a very brief need to know basis. Of course, if you need to know the exact details of any of the medications, then of course there's a paper I'll talk about later on, and there's always the bnf.org. When it comes to pharmacokinetics of anti-seizure medicines, there's a couple of things that you need to know. The first are the enzyme effects, so the cytochrome P450, and traditionally the older drugs are strong inducers of this. Carbamazepine, the barbiturates and phenytoin. Sodium valproate was an inhibitor, and the majority of new drugs fit nicely into the neutral category. Now, obviously, there are a couple of things that you do need to know around about interaction with specific medications, such as estrogen-containing oral contraceptives. And there's a few of the newer drugs, topiramate and lamotrigine, ezecabazepine, which are modest inducers of this, but require care in its use. But in general, the newer drugs have moved away from dramatic effects on the cytochrome P450 system. The other thing I think that's reasonable to know about is half-life. Now, the majority of drugs are short or intermediate, and of course that means that they can then be prescribed either as twice a day doses, very rarely as 3 times a day doses, but usually only twice a day. Why have I mentioned these long half-life drugs in particular? Because actually they present some opportunities and some challenges around their use. And what I want to do is pick up on these 3 in particular. So when you get a patient on zonisamide, perampanel, or the newest drug on the block, cenobamate, one of the things you have to remember is that the half-life of that is very long. I've listed here the half-life, and ezecabazepine I've put here as a long half-life drug largely because the metabolism of ezecabazepine, you've got an active metabolite, which means the effect of it lasts longer than the actual half-life. So you can see that it's shorter than the others. And why do I mention these long half-lives? Well, actually, they're particularly stable. And if somebody's got patchy adherence or a relatively chaotic lifestyle, then use of a very long half-life drug can be useful and avoids any big swings in serum level, such as you might experience with patchy adherence to drugs like phenytoin or other enzyme-inducing drugs. Also means that titration has to be low. Cenobamate comes with a very handy titration pack to make it easier for patients and for prescribers. The other reason for that is that actually if these drugs cause side effects, then rapid withdrawal is possible. You will then get a slow and steady reduction in serum levels, which means that actually very slow withdrawal is not worthwhile. If you're going to withdraw these, you'll tend to do that more rapidly. And that's important in video telemetry, but also important where patients are experiencing adverse effects. And there are fewer interactions with these longer acting drugs, and the exception here is cenobamate, and you may well require a bit of in-depth BNF search to work out exactly what effect cenobamate has on different anti-seizure medicines, because it's got a fairly patchy, induces some and inhibits others. When it comes down to it, though, there's one thing I want to mention about interactions. Of course, there are general interactions around this, pharmacodynamic, but also pharmacokinetic with the old drugs. But there's one interaction in particular that really is a need to know for general neurologists, for neurology registrars, and it's important for a number of reasons. Number one, it's particularly significant. If you're on valproate, your half-life of lamotrigine will at least double, and it's important to know that because you can use 2 drugs together, but you have to be very careful in introducing one to the other in whatever direction that is. The other reason it's important is that psychiatrists will prescribe both lamotrigine and valproate as mood stabilizers, often not aware that Depakote, as the trade name for the mood stabilizer, is valproate, and very often unaware of the interaction between the two. So it's important that somebody knows about it. And I have to say, the only Stevens-Johnson syndrome I've seen in the last 10 years has been a psychiatrist who'd rapidly started high-dose lamotrigine in someone already on valproate, and they presented in an encephalopathic way with a generalized rash, and the assumption was they had an infection, but actually high-dose introduction of this drug, of lamotrigine, lamotrigine to valproate had led to that. So that's it in a nutshell. Pharmacology of anti-seizure medicines has become simpler, which means you've got fewer things to know about, and it gives you a few more opportunities and a few more challenges. Thanks very much.